Good morning, ladies and gentlemen. Today's lecture is part 2 of the topic that I started last week, and that is the neutrophilic dermatosis. Under this heading, last week I discussed two important diseases. They were pyoderma gangrenosum and Sweet syndrome. Both of these two diseases are classified as the neutrophilic dermatosis without vasculitis. So we have already done pyoderma gangrenosum and Sweet syndrome. Now, today I am first going to discuss two neutrophilic dermatoses with associated vasculitis. The first is Bechet's disease and the second one is Erythema elevatum diutinum. Adamantiades-Behçet's disease. Adamantiades-Behçet's disease, also known as EED and also known as simple Bechet's disease, is a systemic vasculitis of unknown etiology involving all types and size of blood vessels. The disease is characterized clinically by recurrent courses of oral abscess ulcers, genital ulcers, skin lesions, which are papillopustules or erythema nodosum, and eye changes that includes iridocyclitis and posterior uveitis. The disease is occasionally accompanied by arthritis and vascular, neurological, gastrointestinal, and other manifestations. But as the description shows above, the main feature are the oral and genital abscess ulcers, skin lesions, and eye changes. ABD most often affect patients in their 20s and 30s. So it's a disease of young adults. However, early and late onset, that is even 72 years, being reported. Currently, both genders are equally affected, with a slight male predominance in Arabic population, whereas female predominance in Korea, China, North Europe, and USA. Pathogenesis. A genetic component of the disease is associated with HLA-B51. Such patients usually have a severe disease. It's an immune-mediated occlusive vasculitis. The pathology reaction is induced by rapid accumulation of neutrophils and later by T lymphocytes and macrophages. A predominant Th1 immune response induced by interleukin-12 is the main cause. In addition to the defective T-cell immunity, B-cell activation is also impaired. Hence, circulating immune complexes, together with enhanced neutrophil migration, may be involved in pathogenesis and clinical manifestations of this disease. Also shows a predilection with various cytokines and inflammatory mediators, endothelial nitric oxide synthetase, interleukin-1, 8, 12, 17, 22, 23, 33, and tumor necrotic factor alpha. The possibility that infections may stimulate an abnormal immune response, for example, Th1 anti-streptococcal activity and antibodies to heat shock protein 60 kilodalton. Prothrombin gene mutation have been reported in patients in whom thrombotic events occur. Histopathology. There are three main types of histopathological reactions in Bechet's disease. The first is vasculitis or vasculopathy. A lymphocytic or granulomatous vasculitis with or without thrombosis, necrosis, and fibrinoid deposits. A paucicellular thrombogenic vasculopathy may also be seen. extravascular with or without vasculopathy. It includes mononuclear cell or neutrophil predominant inflammation of the dermis and the panicles. Then supportive or mixed suppurative granulomatous or folliculitis. Here you can see there is a lymphocytic vasculitis. Mainly the lymphocytes are seen surrounding the blood vessels with some fibrinoid damage, but no thrombosis. Neutrophils are predominantly cells which are seen in the dermis. Here you can see a neutrophilic infiltrate surrounding a hair follicle, even infiltrating the hair follicle. Lesion is sterile. Subcorneal pustules or acneiform lesions are also seen. This is histopathology of an oral ulcer. You can see total loss of epithelium and dense neutrophilic infiltrate within the dermis. International study group criteria for diagnosis of Behçet's disease. This is a very important slide. The major criteria is recurrent oral ulceration. The oral ulceration can be minor abscess, can be major abscess, or can be herpetiform ulceration. But it is important that these lesions should be recurring at least 3 times in one 12-month period. That is, even after every 4 months, if the patient develops this lesion in a span of 1 year, then this fulfills the first major criteria of the illness. In addition to this major criteria, there has to be 2 minor criteria, and the minor criteria are 4 in total. The first of the minor criteria is the associated recurrent genital ulceration. Then second is the eye lesions. Eye lesions include anterior uveitis, posterior uveitis, cell in vitreous on slit lamp, or retinal vasculitis. Then the third criteria is skin lesions. Skin lesions can be erythema nodosum, it can be pseudofolliculitis, or papillopustular lesions, or acneiform nodules observed by physicians. And the fourth criteria is a positive pathogen test that is read by a physician after 24 to 48 hours. So the major criteria, that is the recurrent oral abscess, plus any of the 2 above mentioned criteria, if fulfilled, then the patient is labeled as Behçet's disease. Clinical features, oral ulcerations. Oral ulceration is the defining criteria of Behçet's disease, or the major criteria. Therefore, it must be present in 100% of the cases. Spontaneous healing of apathy occur within 4 days to 1 month. Then genital ulcers. Genital ulcers are seen in 90% of the subjects at one time of the illness. They may not recur as often as the oral ulcers, but usually heal by taking more time and with scar formation. Skin lesions. Of the possible skin lesions, only pustular vasculitis, which is seen in 55 to 83% of the cases, and erythema nodosum-like nodules, seen in 44 to 62% of the cases, should satisfy the minor criteria for the diagnosis. Then pathogenesis. Pathogenesis is the triggering of significant inflammatory response by minor traumatic injury like venipuncture, which is a feature of Behçet's disease occurring in 40% of the cases. Pathogenesis phenomena is also seen or is also positive in pyoderma gangrenosum and in Sweet syndrome. But this is only among the diagnostic criteria in Behçet's disease. You can see the oral ulceration, the oral apathy ulcers. This is a major abscess. These are the minor apathy ulcers. Abscess are seen in the genital mucosa, and then posterior uveitis and retinal vasculitis. The systemic lesions. Eye lesions are included in the diagnostic criteria. They can be uveitis, which is both posterior and panuveitis, which is the main ocular feature. Vascular involvement. In Behçet disease, affected arteries and veins lead to aneurysm or occlusion that may sometimes fatal. Other sites of venous thrombosis include the vena cava, hepatic vein, Budd-Chiari syndrome, and cerebral venous sinuses. The neurological symptoms include parenchymal and durosinus thrombosis and meningoencephalitis, but occur in 3% of the patients. Peripheral neuropathies are rare, and the neurological involvement and vascular involvement is not included in the diagnostic criteria. Joint involvement and GI involvement is also not included in the diagnostic criteria, but the joints are asymmetrically involved in migratory, non-erosive oligoarthritis, seen in 30 to 40%. GI involvement is uncommon, that consists of mucosal ulceration, especially in terminal ileum and colon, which mimic inflammatory bowel disease. The highest risk of serious ocular, pulmonary artery, or neurological involvement in male, especially those with disease onset below 40 years of age. In general, the risk complications gradually decreases if the disease manifests in later ages of life. The investigation of pathogy test. A positive pathogy test, which is an hyperreactivity reaction, manifests within 48 hours as an erythematous papule more than 2 mm or pustule at site of a skin needle prick, or after intracutaneous 0.1 ml isotonic saline solution used with 20 gauge needle without prior disinfection of the injection site. So in doing pathology, we do 1 or 2 pricks by a simple insulin syringe, or inject 0.1 ml of isotonic saline, and then mark the areas 2 centimeters surrounding the prick. The reaction is read after 48 hours, and usually there is an erythematous papule 2 mm in diameter or a pustule. The skin prick is generally placed at an angle of 45 degrees, 3 to 5 mm intracutaneously on volar forearm. Erythema without infiltration is considered as negative. The treatment ladder for mucocutaneous lesions. The first line treatment is topical, that include antimicrobial agents, sucralfate and corticosteroid topical like Kenalog and Orabase, and systemic include colchicine or colchicine plus benzathine penicillin. Second line treatment includes the anti-inflammatory agents and amilexanox. Then systemic corticosteroids are corticosteroid dapsone, azathioprine, and thalidomide. Third line, topical anesthetic and silver nitrate, and systemic zinc sulfate, ribamypide, pentoxifylline, methotrexate, cyclosporin A, interferon alpha, tumor necrotic factor alpha agents. Since the effectiveness of topical treatment is generally limited to the application area, should always be combined with systemic therapy. So as you can see in this treatment ladder, both the first, second, and third line treatment include both topical and systemic treatment. So even if we are using the first line treatments, we are going to give both topical and systemic therapies. Same is the case with second line and third line treatments. Then the treatment ladder for ocular disease. The first line is topical corticosteroids, mydriatics, and cycloplegic agents. And systemic include corticosteroid, cyclosporin, and azathioprine. Second line is tumor necrotic factor alpha and interferon alpha. Third line includes cyclophosphamide and methotrexate. Topical treatment as sole agent should be restricted to patients with mild uveitis. In severe uveitis, systemic treatment should be started in addition to the topical treatment. Then treatment ladder for articular involvement. First line include colchicine plus benzathine penicillin, or anti-inflammatory analgesics. Second line include azathioprine and corticosteroids. And third line, methotrexate, salizopyrene, interferon alpha, and anti-tumor necrotic factor agents. Treatment ladder for GI involvement. First line, sulfasalazine, corticosteroid. Second line, azathioprine. Third line, anti-tumor necrotic factor alpha agents. Treatment ladder for vascular involvement. First line, corticosteroid. Second line, azathioprine, methotrexate, cyclophosphamide, anticoagulants, and surgical intervention. Third line is anti-tumor necrotic factor alpha agent. Then a treatment ladder for CNS involvement. First line, again corticosteroids. Second line, azathioprine, cyclophosphamide, and anti-tumor necrotic factor agents. Third line, methotrexate and anticoagulant. So since there is already a lot of confusion because of different regimes and different indications, so I have summarized the treatment of systemic complications. Whenever there are systemic manifestations in Behçet disease, they are always treated with systemic corticosteroid as the first line treatment. For severe ocular, neurological, or vascular disease, then in addition to corticosteroid, we add azathioprine, methotrexate, or cyclosporin. Caution is used due to neurotoxicity. Cyclosporin may have neurotoxicity. Then, if the systemic complications are not controlled by corticosteroids as well as by immunosuppressives, then the third line agents of tumor necrotic factor alpha like infliximab and etanercept are used, especially for uveitis, although dapsone is more effective inhibitor of pathologic response than etanercept. Now I'm going to discuss the second disease, which is characterized by neutrophilic dermatosis with vasculitis. It's a rare chronic eruption, most commonly seen in adults and named as Erythema elevatum diutinum. Characterized by fibrosing plaques with histological evidence of leukocytoclastic vasculitis, neutrophilic infiltrate, and fibrosis. It is associated with rheumatoid arthritis, celiac disease, inflammatory bowel disease, and type 1 diabetes mellitus. It is also associated with infections that include streptococcal, hepatitis, syphilis, and HIV. Clinical features. Erythema elevatum diutinum lesions are red violaceous or yellowish plaques or nodules occurring symmetrically over the dorsal surfaces of hands, ankle, knees, and buttocks. The lesions may be painful. Lesions may last for 5 to 35 years, with crops of new lesions developing every few weeks to months. So a prolonged and chronic illness. You can see hand and feet are the commonly affected sites. Histology shows in early lesions there is leukocytoclastic vasculitis. You can see the fibrinoid necrosis of blood vessels with background of sweet syndrome like in neutrophilic infiltrate, both perivascular and interstitial. So other than this leukocytoclastic vasculitis, the rest of the feature is very similar to sweet syndrome. But there is in addition another feature that is seen in erythema elevatum diutinum, that is the older lesions show scar tissue with vaguely storiform growth factors. So this is the fibrosis which is typically seen in erythema elevatum diutinum. So erythema elevatum diutinum in summary have three histological features: leukocytoclastic vasculitis, dense neutrophilic interstitial and perivascular infiltrate, and dermal fibrosis. Erythema elevatum diutinum and Sweet syndrome are both described as neutrophilic dermatosis. However, Sweet syndrome is acute, asymmetrical, and located on arm, face, and neck, while in contrast, EED lesions are chronic, symmetrical, and classically located over the dorsal surface of hands and knees. Fibrosis seen in lesions of EED correlates with clinical chronicity. Demonstration of IgA ANCA in 60% of cases of EED has been suggested to be of some diagnostic value. Treatment: like all the neutrophilic dermatoses, dapsone has a remarkable effect on EED, although stopping it often followed by swift return of the lesions. Niacinamide is also used. High potency topical or intralesional corticosteroids may minimize the size of lesions in patients with limited disease. Other therapies used for cutaneous small vasculitis may also be effective in erythema elevatum diutinum. Now we are discussing another category of neutrophilic dermatosis, with a special link to gastrointestinal disease. In this heading, we are going to discuss two important diseases: the bowel-associated dermatosis arthritis syndrome and pyodermatitis or pyostomatitis vegetatis. We have already discussed the peristomal pyoderma gangrenosum in the heading of pyoderma gangrenosum. In addition, aseptic abscesses are also seen in Crohn's disease, and pustular vasculitis and neutrophilic pustulosis, as we see in Behçet's, are seen as an independent lesions as well. Bowel-associated dermatitis arthritis syndrome. BADAS is the presence of pustular vasculitic lesions associated with blind loops of bowel or other causes of stasis of bowel content. The possible etiology is blood vessel damage secondary to bowel flora and antigen-associated circulating immune complexes. So because of the blind loops and stasis of bowel contents, the bowel flora and antigens creates circulating immune complexes that result in pustular vasculitis. Histopathological changes are that of pustular vasculitis, similar to those of Sweet syndrome. Therapeutic response to antimicrobial in some cases support this concept. Bowel-associated dermatitis arthritis syndrome is classified into two main categories: those which are related to bowel surgery and those that are related to bowel disease. The bowel surgeries which are associated with BADAS is jejunal bypass, gastric resection, and blind loops, Billroth 2 or Rook's and Y. Then bowel diseases include ulcerative colitis, Crohn's disease, diverticulitis of colon or jejunum, and appendicitis. Clinical features. The cutaneous lesions begin as small macules that progress into pustules and pustules on a purpuric base, most often on arms and other areas of upper body. The pustules measure 0.5 to 1.5 centimeter and occur in crops, each crop lasting for 2 weeks and recurring at intervals of several months. Arthralgia or non-erosive polyarthritis affecting hands, wrist, and other peripheral joints. Ocular symptoms such as episcleritis occur. Hematuria or proteinuria may also be seen. You can see the pustular vasculitic lesions here and arthritis or arthralgias. Investigation. Clinicopathological evaluation of skin lesions is required but does not exclude lesions of Behçet's disease. So other features of Behçet's disease should be looked for. Pustules should be sought for microbiological assessment. It is advisable to perform urine analysis as there may be hematuria or proteinuria, which possibly represent immune complex initiated glomerulonephritis. Treatment. Surgical correction of bowel anatomy often eliminates the signs and symptoms of the disease. If bowel anatomy is not changed, then systemic tetracycline, metronidazole, ciprofloxacin, or erythromycin. So the systemic antibiotics is the first line treatment. And second line treatment includes systemic corticosteroid depending upon the degree of skin, joint, and systemic symptoms. Other treatment include colchicine, dapsone, and mycophenolate. Systemic immunosuppressant may need to be combined with appropriate antibiotics. So in severe cases, the usual combination is use of an antibiotic with a steroid or other immunosuppressive as well. The second disease under the category of neutrophilic dermatosis with bowel disorders is pyodermatitis or pyostomatitis-Behçet. It is a disorder which is distinct from pyoderma gangrenosum, in which there is oral mucosal thickening with multiple pustules and snail tract superficial ulceration on erythematous base in the oral mucosa, but tongue is less affected. The strongest association is with inflammatory bowel disease, particularly ulcerative colitis. Leukemia, lymphoma, diabetes, and kidney conglobata, hidradenitis suppurativa, and immunosuppressions are also associated. Histology shows intraepithelial or subepithelial abscesses containing large number of eosinophils as well. Skin lesions, if present, are often flexural and clinically suggestive of pemphigus vegetans or verrucous plaques studded with pustules with negative immunofluorescence. So pyostomatitis should be considered in the differential diagnosis of pemphigus vegetans. There may be associated dorsal hand lesions that resemble Sweet syndrome. Lesions may display pathergy. Possible diagnostic clues include raised IgE and eosinophilia. First line management of pyostomatitis is antimicrobials rather than corticosteroid, similar to we see in PADAS. Oral disease may respond to topical corticosteroids or tacrolimus. Systemic prednisolone is often effective when topical therapies fail. Second line treatment include prednisolone or cyclosporin, where dapsone is ineffective. Azathioprine in combination with oral steroid and monotherapy with adalimumab have been effective. Crohn's disease associated cases are treated with combination of methotrexate and infliximab. Then there is another category of neutrophilic dermatoses which are associated with connective tissue diseases or immune complex diseases. Among this category, we are going to discuss here the rheumatoid neutrophilic dermatitis. Other dermatoses are palisading neutrophilic or granulomatous dermatitis, relapsing polychondritis, and Sweet syndrome like Erythema gyratorum repens like, and figurate neutrophilic infiltrate in SLE. Rheumatoid neutrophilic dermatosis. It is likely to be an immune complex mediated disease that tend to occur in patients with severe and active rheumatoid disease. A significantly elevated rheumatoid factor is found with rheumatoid nodules and rheumatoid papules. The lesions or rheumatoid neutrophilic dermatoses occur mainly on limb and face and consist of papule, nodules, or plaques, sometimes with annular morphology, and rarely lesions may be bullous. Sweet syndrome is difficult to distinguish, as well as rheumatoid neutrophilic dermatosis is associated with PG. Histologically, there is dense neutrophilic infiltrate that extends into the epidermis or deeply into subcutaneous fat. Vasculitis is not seen, but leukocytoclasia is seen. Lesions resolve spontaneously or as a result of treatment of rheumatoid disease with immunosuppressive agents. Topical or oral corticosteroid, dapsone, hydroxychloroquine have been used with benefit. The term neutrophilic lobular panniculitis associated with rheumatoid arthritis is of uncertain etiology and is classified as lobular panniculitis with vasculitis. Amicrobial pustulosis of a skin fold associated with autoimmune diseases. Most cases occur in patients with SLE, but can occur in celiac disease and other autoimmune conditions that include autoimmune thyroid disease and autoimmune hepatic disease. In this condition, rapidly evolving small semi-confluent pustules that predominantly affect the flexures, with one major or minor skin fold usually affected, that is face or scalp, causing alopecia. There is neutrophil epidermal infiltrate with spongiform pustules and neutrophilic dermal infiltrate. Positive DIA for IgM, ISC3, and less often IgG is a variable finding. Diagnostic criteria of amicrobial pustulosis is pustules involving one or more major skin folds, one or more minor folds in anogenital area. And number two is the histological pattern of intraepidermal spongiotic pustules and mainly a neutrophilic dermal infiltrate and negative culture. The minor criteria include association with one or more autoimmune disorders, positive antinuclear antibody in 1 in 160 titer or higher, and presence of antibodies to extractable nuclear antigens, anti-double stranded DNA, anti-smooth muscle, anti-mitochondrial or anti-endomysial antibodies must be present. You can see this these kind of pustules which are seen on the flexures. Again, the differential diagnosis can include the candidiasis, pemphigus vegetans, hidradenitis, etc. Differential diagnosis include subcorneal pustular dermatosis, inverse form of psoriasis, and erosive pustular dermatosis of scalp. Management is with oral corticosteroids. Second line, Dapsone or cyclosporin. Topical corticosteroids and colchicine have been reported as useful in some cases. Complete remission after anakinra have been reported. Neutrophilic dermatosis with association with neoplasias or chemotherapy is a known term, and the disease we are going to discuss under this heading is neutrophilic eccrine hidradenitis. This disease is characterized by neutrophilic infiltrates centered on and extend into the eccrine coils. Typically, there is mucinous degeneration around the eccrine glands and a dense neutrophilic infiltrate surrounding the coils and ducts without vasculitis. Early report implicated chemotherapeutic agents, for example, cytarabine and anthracyclines. Some cases, NEH recurs, neutrophilic eccrine hidradenitis recur during successive cycles of chemotherapy. Clinically, the lesions resemble Sweet syndrome. They may affect predominantly the head, periorbital region, neck, and upper trunk, and in some cases can be generalized. Palm or dorsal hands are occasionally affected. If recurrent, they affect the similar sites to those previously affected. Lesions can be plaques, EM-like, urticarial, annular, or pustular. The lesions are painful or tender and associated with fever. Occur at about 2 weeks interval. Occur at about 2 weeks after starting treatment and resolve spontaneously if the treatment is stopped in 2 to 3 weeks. Treatment option, if required, include topical or systemic corticosteroids and non-steroidal anti-inflammatory agents. Dapsone was used to prevent the recurrent episode and started 2 days before the chemotherapy and continued for 14 days. Colchicine is also used with similar modality. Now, under this heading, we are going to discuss some neutrophilic dermatoses which are non-vessel centered and come under the miscellaneous category. The first is the subcorneal pustular dermatosis or Sneddon-Wilkinson's disease, intraepidermal neutrophilic IgA dermatosis, neutrophilic urticaria, neutrophilic spongiosis, and neutrophilic sebaceous adenitis. Subcorneal pustular dermatosis, also known as the Sneddon-Wilkinson disease, is a rare neutrophilic dermatosis with sterile subcorneal pustules typically affecting the flexural areas of trunk and proximal extremities. They occur most frequently in adults 40 to 60 years, more common in females with a female to male ratio of 4:1. SPD is associated with benign monoclonal gammopathy, more commonly IgA, and occasionally IgG, with inflammatory bowel disease, multiple myeloma, lymphoma, pyoderma gangrenosum, rheumatoid arthritis, and SLE. So both neoplastic and autoimmune disorders are associated with subcorneal pustular dermatosis. Histologically, the lesions are characterized by large subcorneal pustules which appear to sit on a normal epidermis. These are the subcorneal pustules. This is the stratum corneum. Again, subcorneal pustules, two views. Subcorneal pustules, closer view. The epidermis is usually normal and only show neutrophilic and neutrophils in transit. Within the papillodermis, neutrophilic and lymphocytic infiltrate is seen. Immunofluorescence in the classical form is negative, but may positive to IgA in a subgroup. Culture of pustules is usually sterile. Clinical features. The eruption occur with acute flares lasting for several days or weeks. The distribution is mainly in fractures of trunk and proximal limb, including axilla, groin, submammary areas, and neck. Lesions are pea-sized or flaccid pustules on a normal or erythematous base. Sometimes larger lesion with a fluid level with pus in lower half and clear fluid in upper half may be seen. Pustules may be isolated or grouped and coalesced to form annular or serpiginous pattern. This is the clinical view of subcorneal pustular dermatosis, characterized by numerous pustules in succinate or spongiform groups or sheets. Such appearance is very similar to appearance in pustular psoriasis. DD include impetigo, pustular psoriasis, IgA pemphigus, pemphigus foliaceus, dermatitis herpetiformis, and acute generalized exanthemic pustulosis. Disease course and prognosis: the course is benign but chronic, and average duration is 5.8 years. Investigation is done by skin biopsy, by DIF, and bacterial culture. Management: Dapsone is the first line treatment. 50 to 150 mg is given daily. Second line include potent topical or oral corticosteroids, acitretin or tacalcitol, narrowband UVB therapy, and retinoid plus PUVA. Cyclosporin in combination with prednisolone was helpful in one severe case. Third line treatment include ketoconazoles and effective use of anti-tumor necrotic factor therapy alone. Two other non-specific neutrophilic conditions: erosive pustular dermatitis, although likely to be suspected when it occurs on the scalp, which is the commonest site. Erosive pustular dermatitis of leg is a rarity and resembles PG. Skin atrophy is typical and may suggest this diagnosis rather than PG, because in PG there is cribriform scarring. Most patients are aged over 65 years. Reported response to oral or topical corticosteroid or topical tacrolimus and colchicine. As occur in amicrobial pustulosis, zinc deficiency and therapeutic response to zinc may be a feature. Neutrophilic spongiosis or granulocytic spongiotic papillovesiculosis. There is an intermittent outbreak of semi-confluent small vesicopustules, predominantly face, neck, and upper trunk, with no consistent relationship with medications, making acute generalized exanthemic pustulosis unlikely. So the lesions are similar to Egypt, but they are not associated with any drug intake and are mainly seen on face, neck, and upper trunk. I thank you all for a very patient listening, and goodbye, and be ready for the next lecture next week. Goodbye and have a good day.